Good morning, friends. Today, myself, Dr. Jayesh Prajapati, Professor and HOD Cardiology, UNMICRC Institute of Cardiology. I am going to discuss on heart failure management, what is current approach. So, we know that the four pillars of the heart failure management and one or two other new pillars are also going to be the future in heart failure management. So, today's topic of discussion is the fantastic four in heart failure, whether we should administer simultaneously or step-by-step approach, and a silver lining in worsening heart failure. So worsening heart failure is also one of the important issue in heart failure management. That is I am going to discuss, and something I want to talk for the fifth pillar, probably the very secret. So we know the heart failure, the stages of the heart failure. Stage A, B, C and D. Stage A is the at present like a primordial prevention. So at patients who are at the risk of the heart failure, so means patient they have not got any symptoms or signs of heart failure, and they have not got without any structural or functional heart disease or abnormal biomarkers, but they are at the risk of heart failure like hypertension, CVD, diabetes, obesity, exposure to cardiotoxic agent like some of the drugs related to chemotherapy, genetic variants for cardiomyopathy or family history of cardiomyopathy. Stage B means pre-heart failure. So patient without current signs or symptoms of heart failure, but evidence of the structural heart disease, and also there is evidence of increased filling pressure. They have got increased biomarkers like we know the NT-proBNP, BNP, troponin I, D-dimer. So biomarkers are helping us so much. Whenever there is a we cannot differentiate it between a heart failure with preserved ejection fraction and the reduced ejection fraction. Now we rely more on biomarkers. They are the prognostic as well as the diagnostic marker. Stage C is the symptomatic heart failure, patient with current signs and symptoms of heart failure. Stage D means advanced heart failure, means patient requires something special like heart transplantation, LVAD or the support devices. So that kind of a recurrent admission. So they require some of the advanced heart failure management like end of life care, something like that. So new ESC guidelines have mentioned something new, that is worsening heart failure. We know that the definitions are modified like heart failure with reduced ejection fraction. Now we come to mid-range ejection fraction, then came with the preserved ejection fraction. Now there are new terminologies like worsening heart failure, improving heart failure, persistent heart failure or heart failure remission. Another is the new onset or de novo heart failure, means newly diagnosed heart failure patient and they have not got any history of heart failure. Worsening heart failure means patient got a symptom, signs or functional capacity, require either escalation of the diuretic therapy or other therapies, and patient requires hospitalization. And another new definition, and including the Victoria, was a heart failure hospital within 6 months or outpatient IV diuretic use within 3 months. So patient require intermittent, suppose they are going into some nursing home taking IV diuretics or requires hospitalization rate. Improving heart failure, we have seen that some of the postpartum cardiomyopathy or some of the cardiomyopathy or the ischemic cardiomyopathy, they improves. So these are the improving symptoms of signs and functional capacity of heart after heart failure management. Another is the persistent heart failure. So persistent heart failure with ongoing symptoms or signs of heart failure and limited functional capacity. Another is heart failure remission, means resolution of symptom and sign of heart failure with resolution of previous structural functional heart disease after a phase of symptomatic heart failure, like we can say Takotsubo cardiomyopathy, some of the recoverable causes of the heart failure. So that is something what we want to, something new, and that we should mention in our history paper also. So classification trajectories heart failure beyond based on LVEF, as I told, reduced ejection fraction means ejection fraction less than 40%, and they have got a. Another is the heart failure with reduced ejection fraction, of course yes, less than 40. Another is the improved ejection fraction. After 40% they have improved to more than 40%. Another mid-range ejection fraction 41 to 49%, that also with reduced ejection fraction, mid-range ejection fraction, and of course either they mid-range ejection fraction go into three directions. Either they reduce more to become a heart failure with reduced ejection fraction, mid-range remains same, or they can get an improved one. Another with the preserved ejection fraction means more than 50%, and they are either going to reduce ejection fraction, mid-range, or remain the same. Another, how we treat this kind of patients. So according to the ESC, Means step 1, this is a stepwise approach. So step 1, step 2, step 3, step 4, 5 and 6. So step 1 includes the management. If the ejection fraction is reduced less than 40%, these are the patients we reduce a class, means stages C and D. Means naturally they have got a sign and symptom. So either they should be treated with the ERNI, either first choice, or ACE inhibitor, or the ARB is a constant issue. Beta blocker is a must, MRA, SGLT2 inhibitors, and diuretic when as a required, patient is volume loaded, we should give them a diuretic. And they either improve or remains the same, and then the management go accordingly, and we have to continue the guideline directed therapy for such kind of patient. So step 3 means patient they are going to reduce ejection fraction, they move forward. Either they become a reduced ejection fraction, or they either go to improve, and then we have to think for the other things. We can add a contraindication, then we can go add on either isolazine, or patient have ejection fraction less than 35%, more than 1 year survival, we can put ICD also. Patient, those are the indicated cases, like the QRS duration is one of the important criteria. Patient having sinus rhythm and QRS duration more than 150 with LBBB, we should go ahead with a class 1 indication is a CRTD, the combo device, and RBBB also very wide QRS complex, we can go with a even with a CRTD if there is a septum desynchrony is there, then that way we can move ahead. It still the disease progresses and patient worsens, then we have to move beyond the thing. We have to go for mechanical circulatory support, we have to go for the cardiac transplantation, and of course at ultimately last stage we have to go with a palliative care that we have to keep in mind. So another, these are the certain registries, and they have shown that even we know everything, most of the patients not on the guideline directed therapy. Only few patients, see is National Heart Failure Registry data says ERNI usage is still very low, less than 4%, and most of the all the 4 drugs patient receiving after 6 months, even the Pinnacle registry also says that not all the patient receiving all these 4 fantastic pillars of the heart failure. So we know that based on what these guidelines they mention all these 4 drugs. So one is a Paradigm HS, the largest clinical trial has shown that this molecule, this reduces the 20% primary composite outcome relative risk reduction, CV death and hospital. So this is 2020. If don't know, we have to say 20% reduction in primary composite endpoint, CV death, heart failure hospitalized with this molecule compared with enalapril. And of course, it reduces the hospitalization also, 40% reduction during the first 30 days, and of course cumulative number of hospitalization also for heart failure per 100 patient rate 23% reduction. And of course it improves the functional status. See, if we start only 1% where, and that has those 26 to 28% of the patient achieve NYHA class 1 status with this ERNI by 26 week. See the NYHA class 1, see the improvement. See before discharge 11%, week 10 21%, 28%. So patients start improving as early as before discharge also, week 10 26 we can see remarkable difference and reduction in NYHA class. That is what dramatic response we can get with a ERNI. So ERNI impacts the non-fatal clinical deterioration also. So ERNI prevents the clinical progression of surviving patient with heart failure significantly more than enalapril. So survival benefit is there when we see the recurrent hospitalization, emergency department visit, even the IV inotropic uses or the implantation of CRT also. So patient improves more with this such kind of molecule. Another, we have to see the gap, frequently heart failure progress, see the median gap. So gap number, days from discharge to death. So median gap between the first and second hospitalization, that is decreased. So we have to reduction. Suppose patient has been discharged with optimal medical management, then of course patient at second time admission will be delayed if we treat such kind of patient properly. This is one of the important side or good slide I can say. So hospital is a key moment to optimize the medical therapy both in the pre and post discharge phases. So admission, and when we discharge the patient, before that at least we should start most important therapy, and we have to manage on a trajectory track. Initially patient may be acute decompression, patient require diuretic, hemodynamically not stable. So once patient become hemodynamically stable going into the ward, we have to think for all the kind of drugs. So improving towards the target So we have to optimize the outpatient care and we have to treat the patient with guide-directed therapy. So optimization patient transition to the oral therapy till the discharge, we have to give almost maximum possible guide-directed therapy. And when the patient comes during the first follow-up, early post-discharge phase to transition to the chronic phase, we have to at least we have to initiate within 1 month, we have to initiate all the 4 pillars. So guide-directed medical therapy, that is one of the important therapy. So from ICU to the ward to the discharge, peri-discharge phase and first hospitalization phase, these are the crucial phase for heart failure management. Even the acute heart failure once becomes stable, we have to think for the chronic heart failure management. So timing is most important. So acutely hospitalized heart failure patient, early intervention improves the long-term outcome. Yes, of course, yes. So intervention restricted to an early phase, the sooner is the better. So we have to emergency department to the ICU. Of course, we have to manage with inotrop, diuretics and whatsoever. But once the patient, even the studies are supporting such kind of things. So these are the various trials. Pioneer HF means patient with Ernie, Victoria with Vericiguat, Soloist with a SGLT2 1 and 2 receptor antagonist, sotagliflozin, FOM-HF and Impulse with empagliflozin has shown that earlier, even the earlier phase, we should give peri-discharge phase. If we give all this molecule, patient will benefit much more. So what about Pioneer HF study has shown that sacubitril/valsartan has reduced 29% reduction NT-proBNP, risk of mortality, reduction in rehospitalization, transition trial also. Heart failure patient, hospital acute decompensation heart failure, and it has shown that first hospital admission and first CV death also reduced. So these are the 2 studies has supported this molecule during the hospitalization phase for discharge. So this is one of the important thing. Even the ACC 2022 guidelines mentioned that ERNI nowadays not like patients who are not unable to tolerate the ACE inhibitor we should put on ERNI, but ERNI should be a first line therapy. In patients with heart failure with reduced ejection fraction and NYHA class 2 to 3, the use of ERNI is recommended to reduce the morbidity and mortality. In chronic symptomatic heart failure, reduced ejection fraction, class 2 or 3 who tolerate even ACE inhibitor or ARB, they should be replaced by ERNI. That is one of the important thing because we want our patient to live long. ERNI is recommended as de novo treatment in hospitalized patient with acute decompensation heart failure before discharge. So ERNI should be started before discharge and this can prevent. See the number needed to treat in slide is of course goes in favor of ERNI. So even the Emperor trial has shown that with empagliflozin, it has shown that reduces CV death and heart failure hospitalization. So 19.4% patient with EMPA group experienced CV death or worsen heart failure over a median follow-up of 14 months. So even patient, there are some of the, of course they benefit, but some of the still there is some of the residual risk is there, and that we have to, even with a deliver trial also, they have shown that there is some residual risk even after giving all this four molecule, and that's why we need another molecule to give that drug. So component of primary worsening heart failure even still occurs after giving all these molecules. So how much benefit we give by 4 pillars? So ERNI they reduce 28%, relative risk, and 2 years mortality benefit 25%, beta blockers 35%, aldosterone antagonist like spironolactone, apelin 30%, SGLT2 70%. Of course they have got a mortality benefit. So cumulative risk reduction in mortality, if all evidence based therapies are given, relative risk is 73% and absolute around 25.5%. So that is dramatic response what we give. So these are the important pillars. As I told, we have to treat this kind of patient with ERNI, beta blockers, MRA and SGLT2 inhibitors. So even if this is what is a mean, so 55-year-old patient, if we give all the 4th pillar of the therapy, we can prolong his death, comprehensive therapy and conventional therapy. So if we go conventionally, one by one conventional means start one molecule, go maximum dose, second, third, so it will take 3 to 4 months. So conventional therapy compared to that comprehensive therapy, start what following more 1 month time, that gives more benefit in young patients. So what is the mean of sequencing rather than what I told that conventional and this approach? So conventional approach sequence for initiating heart failure reduces by order in order, 1 then 2 and 3. But here we have to give a comprehensive therapy. So When we delay it, we cannot get a much more benefit. So delay by starting the therapy is demonstrated to reduce the morbidity and mortality within the first 30 days. So first 30 days is crucial. So we have to give all the 4 pillars in early phases to give the maximum benefit. So how we can give it? So step 1, step 2, step 3. So first line therapy within 4 weeks. So start with the SGLT2 inhibitors. We can give, if we can start at any stage. So SGLT2 and beta blockers has shown the highest benefit. So we start with a mild to moderate dose of beta blockers, like we can start with a bisoprolol 2.5 milligram, even we can start with a 1.25 milligram, and then if the patient blood pressure is more than 100, even sometimes 90, we can go with early low dose. We can start with even Indian patient, we are starting early as dose of 50 milligram half BID, and then we can go above. And of course MR is 25 to 50 milligram is not a bad thing, not much hemodynamically damaging. So MRS can be given. So stepwise approach is like this. So morbidity and mortality with low starting doses can be reduced, and magnetic treatment benefit each drug class independent of background heart failure reduction therapy, and improve the safety and tolerance. This patient tolerates. So we can start 4 pillar in a moderate doses, and then we can titrate in the future to give the maximum benefit. So conventional sequencing, as I have told, go with a ERNI or go with a conventional approach like ACE inhibitor. If not tolerate, we go with a ERNI, start with a then beta blocker, then MRA, ERNI, SGL, not a good approach. So start with a day 1, we can start with the SGLT2 inhibitors, and we can initiate a low days, either a beta blocker or the ERNI. 7 to 14 days, we can continue all this molecule, and then we add on the 1 by 1 molecule, and 42 days, after 1 month, starting all the 4 drugs, and then we start with the increasing doses. That's why we can get a maximum benefit, CV death, mortality benefit, we can say around 60% benefit we can give it. So simultaneous initiation and continuous of each medical therapy may improve the tolerance and adherence to the patient. So suppose we start all the drugs, initial phase, always we have seen that once the patient has been discharged and comes for the early follow-up, because patient have got a symptoms and they are ready to believe in you. And if you start the treatment early, patient will always love to take it. Gradual approach, usually patient lost to the follow-up after 6 months, 1 year. So earlier is always better, patient adheres, and we can know that patient is tolerating the drug, and we can monitor the side effect. So that is the advantage of early initiation and rapid sequence therapy for the quadruple management. So important thing is that Fantastic 4, Fabulous 5, and Flight 6. So 4 drugs, only beta blockers, MRA, SGLT2 inhibitors, 5 mechanistic pathway. We know that angiotensin 2 with ACE inhibitor, neprilysin, that with the only sympathetic with beta blockers, mineralocorticoid, of course, with the eplerenone or the spironolactone, SGLT2 with EMPA, DAPA, or the KENA. And we can get a 6 additional year for the survival if you continue with this kind of therapy. So, and how? This is one of the very good slide. It's very busy slide, so I not go to detail. But these have shown very important drugs that can also patient, if the patient has got a tachycardia, is there even after maximum dose of beta blocker, or because of hemodynamic problems we are not able to increase the beta blockers, then of course we have to try with the ivabradine also. So ivabradine has been included. Patient with a low eGFR, we can give up to some say up to 25 or 30 eGFR, we can give the ERNI, but less than that we can add isolazine. Even if the EMPA, we can give up to eGFR of less than eGFR of less than 25. Beta blockers, bisoprolol or the metoprolol can be given at any stage of CKD if the patient blood pressure is good. Spironolactone, of course, with a very low GFR, we cannot give because of potassium. Potassium is a problem, so we have to monitor the potassium. Another is a good molecule is a vericiguat. Vericiguat can be given even up to eGFR of 20. We can give a vericiguat. Even the hemodynamically borderline patient, we can give a vericiguat starting dose of 2.5, 5 and 10. We can give a vericiguat also. Omecamtiv not approved by the FDA. Atrial fibrillation, we have to control the rate, and we have to, of course, patient with arrhythmia, then of course we have to give them a benefit of ICD or the CRT also. And the sinus maintenance is a good thing. If we can, we have to give the anticoagulation also if the patient with atrial fibrillation as per the guidelines. And of course we have to control the rate either with the beta blockers or the amiodarone when needed, and of course if we have got a tachycardia, we have to get the help of EP specialist to control the arrhythmias also, like VT ablation and all. So another worsening heart failure, this is the last part of the talk I want to discuss. So persistent NYHA class 3-4, more than 2 emergency department visit or hospitalization for acute heart failure in 12 months time. High risk for the biomarker profile, hyponatremia, where you are persistently elevated NT-proBNP, inability to up-titrate the guideline directed therapy because of hypotension, BP less than 90, dizziness, worsening renal function at extra. Onset of arrhythmias, atrial fibrillation, VT or ICD or the shock. So another required escalation of the diuretic, like more than 160 mg of ULS6, or the persistent edema despite escalating diuretic dose, even if we had a metolazone. Need for the IV inotropic. So these are the group of the patient we have to think for they are considered to be worsening heart failure. So what about India? Indians are different. So we have got a high disease burden because of coronary artery disease, diabetic population, and Indians, they have got early heart attack because younger MI, they are 10 years younger compared to the western part. So we required to give them a guideline therapy much more. And cause of the CAD is the most common etiology for India, followed by the RHD. Hospitalization, 1 out of 5 heart failure reduced fraction, re-hospitalized within 1 year. So this is tremendous thing. So 20% of the patient. Mortality, 5-year mortality. So see the 5 year, 3 out of 5 patient, Indian patient, they have mostly die. So median survival 3.1 year. And cause of death is a worsening heart failure, repeated hospitalization leading to the death. So that's why we have to treat the worsening heart failure patient very well. So the real world data is 17% of the patient they develop worsening heart failure. So this is worsening heart failure is a marker of increased risk of mortality. So repeated hospitalization, worsening symptoms, increased dose of diuretic, we have to be very aggressive. So 1 in 5 patients died within 2 years of the first worsening heart failure event. So 22.5% increased risk of 2-year mortality in patients worsening heart failure as compared to no worsening heart failure. So once the patient has got a worsening heart failure, they are going to be readmitted in near future. So which are the targets? So outpatient worsening heart failure is also one of the definition given. Deterioration of heart failure signs and symptoms. Patient with chronic heart failure, after a period of chronic clinical stability that require escalation of therapy without an urgent need of hospital or ED presentation. Even the patient not hospitalized, but patient require escalation of diuretic therapy on OPD basis, they are also to be considered as the worsening heart failure, and that always we have to keep in mind. So we have to see for the baseline risk 3 to 6 months, and we have to see for the if there is residual risk, and we can treat such kind of patient with devices like ICD, even ICD in selected group of patient has some of the mechanical causes that we can correct, like of course patient with ischemic cardiomyopathy, we have to do the angioplasty, or we have to patient should undergo a bypass surgery, or patient have got a regurgitation, then mitral clip or the mitral repair or the aortic structural disease should be corrected. Even still where patient having a worsening heart failure, even after giving all these things, we have to add on the drug therapy like Vericiguat, and then we have to go with a final things like mechanical circulatory device, we have to give them IV inotrop, we have to put them a LVADs or cardiac transplantation, that also to be thought of, or end of patient's medical management, end of care life, that also be thought of. So some of the patient, as I have told, even after quadruple therapy, patient still symptomatic, and despite the use of all such kind of management, then even the omecamtiv also, galactic heart failure, also shown some of the benefit but not approved by the FDA. So patient following the worsening heart failure event are a distinct population, requires something special things. So where this group gap is filled by the Vericiguat. So that is a different pathway. Vericiguat is a nitrous oxide cyclic GMP pathway that improves the metabolic pathway and improves the heart failure, and relatively hemodynamically neutral, not much effect on the potassium. This is one of the beauty of the molecule. So fifth pillar we can add on to improve the recurrent hospitalization for heart failure, but that not very effective in very sick patients. So if the BNP is very high, not much effective. So earlier is sooner is the better. With very sick gut, we can start with 2.5 milli to 5 milligram once a day, and we can go up to 5 milligram. So always our heart failure patient should be managed in a proper manner, and they should be given all kind of treatment rather than the conventional approach. We have to go with a step by step. Earlier is always the better, and all the 4 pillars, so they should be given. And if required, symptomatic chronic heart failure and after a worsening heart failure event, as per the definition, patient is hemodynamically stable, more than 100 BP, of IV therapy, more than 24 hours patient. There is no run-in period in Victoria trial. So Victoria trial has shown that symptomatic chronic heart failure with ejection fraction less than 40 NYHA class 2 to 4 on available heart failure therapy, and they have got a worsening heart failure, means less than 3 months after heart failure hospitalization, and IV less than 3 after IV therapy or elevated natriuretic peptides, and this patient, if they are more than 100 BP and off inotrope, they were treated without run-in period, and this molecule has shown that they have got an event rate has reduced, and absolute risk reduction of 4.2 events per 100 patient. So annual number needed to treat were 24% for hospitalized event. So hospital events were prevented in Victoria trial. So nowadays very sick gut has been approved by this guideline ESC 2021 and CCH heart failure guideline, AHA, ACC, HFSA guideline has shown and given that very sick gut may be considered in patients with NYHA class 2 to 4 who have worsening heart failure despite treatment with AC inhibitor, ARB, beta blockers, MRA to reduce the risk of heart failure, CV mortality and heart failure hospitalization, class 2B and level of B, and of course the conditional approval given in CCS guideline. AHA, ACC also given that 2B and B2 are recommendation in selected high risk group of patients with reduced expression resenting versus heart failure. Already in GDMT and oral SG, this very sick gut may be considered to reduce the hospitalization and CV death. So but important thing is that how we are in India, we are not giving only, these are the registry, we are also part of this registry, and have shown that we are in India, not most of the patients are not on this 4 therapy. So that we have to keep in mind, and this approach, the rapid sequences approach should be followed. That is what my crux of story, rather than going to the conventional therapy. That is how we have to treat it. And we can see that even needed patient, very sick gut, if we can give it, we can prolong the repeated hospitalization and worsening heart failure, and patient can live longer. So this is what I want to say for the heart failure management. So always we have to stick the guidelines, GDMT therapy, and patient should be insisted, and regular day-to-day follow-up. As the patient progresses, we have to think beyond the medical therapy with the devices also, ICD or the combo device, or we have to think for the given the up to cardiac transplantation, and whenever needed there's some structural diseases there like mitral clip or aortic replacement or the revascularization, that should be done. And of course new pillar we should not forget, the very sick gut for heart failure management. Thank you so much.